Let's start off with a keynote address by Dr. Taraprasad Das. I'm sure Dr. Das doesn't need an introduction here. He's my teacher. He's a renowned vitreoretina specialist and into basic research now. Dr. Das will give a keynote address on eye care policy planning in people with diabetic retinopathy in India and South Asia. Over to you, sir.
Thank you, Thomas, and thank you, friends. And good to be in Thrissur in KSOS. My first meeting actually in KSOS, though I've gone to Cochin or Trivandrum, Kerala several times. When Thomas talked about it, I offered him two topics. One is this, which is a public health policy, because very important to have public health policy for whatever health care we do. And two is a very, very basic biological research, molecular biology research, which Andy preferred to this, and let us talk about this. Before we talk about the health policies for DR care, talk about these few terms are used very repeatedly and explain to you what they are on the health system. What is the socio-demographic index called SDI, what is the epidemiological transition level called ETL, and finally, what do you mean by daily disability adjusted life years. Health system has got two principal actors. One side the people who consumers, people who receive our patients, and two the providers, either the health providers like public or private or voluntary, non-for-profit, or the state, which let's say in India, health is a state policy. There are two important inputs. One is the finance. Finance is revenue generation and revenue and purchasing power of people. And the two is the knowledge of pharma industry participation and the technology that we are changing every time. This all together give to a service delivery for public, private, inpatient, outpatient, etc. But ultimately build a system which is not only for cure of a disease but also health protection. It is much more important than cure of disease, and build a trust in the system. When you say that I am become unhealthy, I will taken care of, the system trust is very important. This all lead to a oversight of the entire system called the regulation, information, policy, planning, strategic, then partnership between the government and the public and private partnership, etc. When we talk about the SDI, three important factors. One is what is the income per capita per person. That means what is the average education for the people above the age of 15, and what is the fertility rate below the age of 25. And then SDI goes, certainly 0 is the lowest, but then higher SDI, which is more than 0.6, means there is a higher education, a lower fertility, and higher income per capita. ETL is the other way around. ETL is the ratio between the all common maternal communicable neonatal diseases divided by all the NCDs plus the injuries. Here, higher ETL means more double. That means more injuries, more non-communicable disease than compared to people dying of infection. So these two are important. Finally, the daily is the measure of disease burden expressed as the number of years lost either because of disease or early death. As is shown here, there are small time death, but then they will die before. These four factors actually decide how healthy we are, how healthy the state is, and on the entire communication based on this. ETL has got four different categories. One is before early 17th, 18th century, when there is a pre-Renaissance days, so where there is a higher morbidity and higher mortality, higher birth rate, but because of higher mortality infection, the population is very, very slow. As you grow after Industrial Revolution, the population grew, then the fertility increased, so population will grow. This is called population boom that we had, India still has got most probably. As you grow further, then we know how to control our fertility. So mortality become less low because of our health system improved. The slowly population went down. But today, when we are in 21st century, because of even though there is a low fertility and more knowledge, because of better health system, our population is low, but then we are dying because of non-communicable diseases. So where we are actually, we are somewhere in the middle. Then India or entire South Asia, Afghanistan, Pakistan, Nepal, Afghanistan, Sri Lanka, Maldives, the South Asia countries, we are somewhere in the middle, where our infection has come down significantly. So do not die of polio, do not die of malaria, do not die of rubella, something like that. But then non-communicable disease increase because of many things. Lifestyle changes, our not controlled diabetes, hypertension, etc., etc. So we are here. This actually decide where do we go from here. Unfortunately, so-called developed countries are in higher there. So USA, UK, Japan, France, Australia, they are not no more actually controlled society. Where do we stand? In India, so we divided all the states and union territories. There's published paper in 2016. It will not been done after that in India, unfortunately. There are five states are actually higher ETL, and Kerala is one of them. Others are Goa, Himachal, Punjab, and Tamil Nadu. That means you have got a lower mortality, health index is better, SDI is better, income is better, but non-communicable diseases also are higher. If you look at the three other factors, the Human Development Index and the poverty index and the out-of-pocket spending called OOPS spending, then India is somewhere in the middle of the South Asia, SDI is 0.6, multi-dimensional poverty is 16.4% people are actually poor in the country, then 50% people pay out of the pocket. In Kerala, however, there is a better SDI at 13% better SDI than India average, 95% lower poverty than India average, but the out-of-pocket expense is much higher, 34% higher than what normally people in India will pay from their pocket for healthcare. This is the India average of diabetes and diabetic retinopathy, and Kerala is highlighted here. We have got 25.5% of DM, 22% of any diabetic retinopathy, and 5% of DR, which is much higher than the India average shown here. But diabetes is not a standalone disease. If somebody thinks that diabetes, nothing happens, it is not really true. And we published a large paper of 11,000 people, entire country from North Punjab to Tamil Nadu, that hypertension is very, very common. 58% people have comorbidity, and hypertension is the most common of them. As similar to diabetes, retinopathy is also not a standalone disease. Incidentally, the amount of people of diabetic retinopathy who have cataract is very high, which is 77.7%, which is non-operated or operated together. But why I'm talking about cataract in a situation like a diabetic retinopathy? Because the cataract actually signifies the robustness of healthcare or eye care for this matter. In India today, CSR is 59 or 6,000, which is very, very high, but desired actually 9,000. That means we are still behind even though we are doing so-called good. Let's see what actually happens. This is a beautiful graph which shows that as you develop further, your health system actually depends on how well you do a cataract surgery or how effective you do cataract. For example, look at the countries, USA, France, Netherlands, Japan, Iran, all are doing much better than compared to Brazil, Chile, Cuba, China, South Africa, etc. Because please do not say that I don't care for the cataract. That is the basic of the eye health system actually. So how do you treat that? Means retinopathy. You do a screening, either biochemistry or a fundus photography. You identify between NEDR to STDR. STDR requires immediate treatment. They then do either laser, surgery, injection, depending on the status of the retinopathy, and do a follow-up care. But the published paper, I think 6 months ago in Lancet Global Health, we published that Smart India study found that 28% of the times you cannot take a fundus photography because of lens opacity, which means that these guys require a surgery for cataract first or care for cataract first before you think about diabetic retinopathy. So that's also the study identified 3 important criteria. People who are older than 50 years of age, diabetic duration more than 6 years, and people with a systemic blood pressure of 440 millimeters of mercury have a higher risk. If you use these 3 criteria alone, then in a screening strategy, 93.5% people were able to screen well. That means you are not losing too much. In a resource-restrained situation, not Kerala though, situation where you do not have all the resources, then at least you people screen people above the 40, 6-year diabetic duration, and blood pressure of 140 over 90, then most probably 93% of times you can identify STDR. Look at this, the India scenario. Now, Government of India said last year we operated roughly 8 million cataract, and then Smart India study had identified that 4 million people of India have required treatment for retinopathy. If you convert that into money, then you require 96 million US dollar for cataract surgery and 154 million for retinopathy care. So what you will do first? You might hate me, but then health policy wise, you should don't ignore the cataract while not ignoring the retinopathy. And then cost of is that for individual is three times, for the country wide 3 times more expensive than doing a cataract surgery. So where we are today, we projected that IDF says that 74 million people have diabetes in India. But recent paper in July published paper of one group from Madras says that actually 101 million people of India have got diabetes, but along with the undiagnosed or pre-diabetics, there are 237 million, and importantly that 315 million have got hypertension, and obesity is 254. In general, all India studies shown that urban is more than rural, diabetes or hypertension or anything else. But unfortunately, this is blurred in Kerala. Now, in Thrissur, the study says that retinopathy is higher, so also maculopathy and STDR. In Kerala, says that diabetes is much more than in India, both diagnosed and undiagnosed, so also hypertension, obesity, and abdominal obesity. Look at those beautiful figures published in Lancet Global Health, that is urban, rural. Look at those figures that both are red, that means blurred between diabetes in urban and rural, so also pre-diabetic, so also hypertension. That means in Kerala, nothing called rural, it's everything is urban. So also obesity. So considering that the cataract surgical rate is very high in Kerala, almost 5% more than India average, we do not have the data for CSR and effective cataract surgical coverage. Considering that even a state like Tamil Nadu, higher cataract surgical rate requires, still there is a huge gap in effective cataract surgical quality of the cataract surgery. We have to improve also the cataract surgery along with everything else. This aligned with the WHO recommendation for the integrated people-centered eye care, from advocacy in the community to tertiary care and higher level. My suggestion is that Kerala requires to improve the cataract surgical rate also without ignoring the diabetic retinopathy. Thank you very much.
Thank you, sir. Just one question from my side. When you go ahead with these policy plannings that Kerala requires a better cataract surgery site, more screening and all, don't we have to look at the health-seeking behavior of the population also?
I didn't understand the second line. What is the second line?
Don't we have to look at the health-seeking behavior of the population also, rather than screening and treatment?
Yes, advocacy. The advocacy to reduce the hypertension, reduce obesity, and change your food habit. This has to happen in the lower level in a so-called health wellness clinic or primary care center, then go upwards. As the SOAS paper talks about that Kerala diabetic retinopathy pathway, you don't require to do you require universal screening, don't have to do those targeted screening. We are doing very well, but then incidentally still we are behind, so Kerala can be a good model, can be a better model for the country to how to do the policy planning for DR. The problem is that we retina guys always say screen and treat diabetes, but can't ignore cataract eyes, because people are older people, they will have cataract, it's not a disease, will have a cataract also. So that is why my suggestion is that when you improve the system, improve the entire system, just not the retinopathy or screening or fundus camera, etc., also how to improve the cataract. That will improve the availability of human manpower, a lot of personnel, cataract surgery, infrastructure development, everything will go together. Then you can do much better than what we are doing today.
Thank you, sir.